I'm Ben Ryman, and this is Behavior Speak. In this episode, Dr. Kacey Bedard delves into the various research and intervention strategies for individuals with Prader-Willi Syndrome, focusing on hyperphagia and skin picking. Dr. Bedard discusses the development of a remote parent training program, the importance of food security, and the balance between restriction and freedom in care. She also highlights the significance of early intervention and future directions for expanding access to these programs. Welcome, Kacey.
Thanks, Ben. Good to be here.
Yeah, stoked to have you. Before we get started, I just want to acknowledge I'm producing this podcast in the lands of the Comox, Playhouse, Komoko, and Tla'amin First Nations. Grateful to be here. Kacey, tell me a little about yourself.
Sure. So I currently teach in a Ph.D. program. I'm an assistant faculty at the Chicago School of Professional Psychology, which has now been shortened to the Chicago School, but still getting used to that. And I've been doing that, been doing that just since January. Before that, I was a student at the Chicago School and then a postdoctoral fellow. And during my time, both as a student and as a postdoc, I focused my research on Prader-Willi Syndrome, which I know we're here to talk about today. And let's see what else. I'm a BCBA at the doctoral level. I have lots of experience working in residential settings for adults with developmental disabilities and significant behavior. I think that's about it.
Right on. So, how'd you get into behavior analysis in the first place?
Though it was a complete accident, believe it or not. I was working at actually a clinical psychology and psychiatry clinic that also did research, and I was working on the research side. And I really thought that I wanted to go into clinical psychology. Thought that's what I wanted to do. And I worked there, and it just really didn't click for me. I wasn't enjoying the clinical psychology side of it. And I was kind of confused about where to go from there, because I was like, I know I want to help people. I know I want to be in the field of psychology, but this is just not landing for me. So what ended up happening was my boss at the time said, listen, I'm going to tell you exactly what you're going to do. You're going to turn in your 2 weeks. You're going to go to this ABA company. You're going to apply and just go work there as a behavior tech and see how you feel about it. And the place that she recommended that I apply to was actually, it was a behavior analysis company that was housed within a large residential program for adults with developmental disabilities who had significant behavior problems. It was an intensive behavior program. And so I went and applied there as a behavior technician, not knowing what ABA was, not knowing what I had taken an ABA class in undergrad, so I barely knew what it was, but not really. And I loved it. It just filled my heart up. It was the most fun job I'd ever had. So I ended up going and getting my master's, and they hired me as a BCBA. And then I ended up working there for 6 years before I left and started my own company and went back for my PhD and all of that. And it just so happened that this program that I worked for had a large group of people with PWS. So we had 80 adults with PWS as part of our program. And so that's the majority of my caseload ended up being people with PWS. And so that's kind of how I got started. But it was a complete and very happy accident, because I love behavior analysis and I can't believe that I got lucky enough to just stumble into it.
Mm-hmm. So this was your first time in the residential program too, because you say you're really into working in a residential program. So this was your first experience in one?
Yep, that was my first experience in one.
And so what was this place like? Because I think a lot of people have different sort of visions of what a residential program looks like. For some, it's, a group home. For some, others, it's a massive institution, and for some, it's just somebody's house.
Yeah, no. So this was actually a fairly large program. I can't remember how many residents we had in total, but we had kind of a combination of different settings. So we had group home settings where we had anywhere from 3 to 5 residents living together in a home that was staffed 24/7. And then we also had, it was kind of like it wasn't really like a transitional setting. It was more of like an independent living setting. So we had apartments that were set up. They usually had 2 or 3 residents and 1 staff member living there. Usually it was 2 residents and 1 staff member. And the staff member was essentially, sometimes they worked with the residents in the day, but mostly they were just the overnight support. However, we didn't have any awake support there. So it was just a staff member living there for cases of emergency. And then they had daytime staff that would help them as well. So that was more of an independent living setting. And in that setting, we had many residents, including some residents with PWS, who actually had government jobs and would take the bus and go to work and were very independent. Whereas the group homes we had different types of group homes. So some were behavior-focused group homes, which had some clients that had some behavior concerns, but not anything significant. And then we had our intensive behavior homes, which were our clients with the highest need. And then we also had some non-behavior homes. So some residents that people just needed some extra physical support. So we kind of had a broad range. And then we had a day program as well. So at the day program, people could come, they could work, they could learn, they could exercise. We had all kinds of community programs. We kind of offered wraparound services, and it was a fairly large program.
And were these programs like all on one big campus, or were they just all over town?
All over town. Yeah. So we had houses that were rented all over. All of our apartments were in the same apartment complex, which was walking distance to our day program and work setting. But the rest of the homes were spread out all over town.
I'm happy to hear that. I struggle sometimes with the big giant campus sort of gated community of all disabilities and nobody else. And, so having that community inclusion piece, I think, is really important.
Sometimes it was a benefit and sometimes it was a challenge.
Absolutely. And how was it? Like, how was the community and how did you sort of work with, folks that struggle to have you folks around?
So I will say that the community, generally speaking, was really great. We tried to be really respectful of the neighbors. I mean, sometimes when you have people with significant behavior problems, that can cause problems for the neighbors. But generally speaking, they were really either kept to themselves or they were really friendly with our residents, and we didn't really have too much trouble. The other thing that I think was helpful was that we made a lot of effort to make contact with the sheriff's department and the police department. We made sure they knew who all our residents were, what their concerns were, who to contact, how to work with them, and we met with them on a continual basis. So I think that helped as well. So that if we had a resident that was having a problem, the police would know them and were able to de-escalate. And if, for example, if somebody had eloped, they would know who the person was, they would know who to contact. And I think that helped a lot with public relations as well. I was just going to say, I think I was lucky with this program because I know some people have had not as nice experiences with residential programs. And I will say that this place was really lovely, really, really fun to work at. We had lots of behavior support. We had lots of staff support. So I think that definitely goes a far way. And the people, I think it helps when it's a nonprofit and the people in management are really focused on client care. And at this place, they were really focused on client care and person-centered planning. And that, I think, went a far way.
And is this the same place that I read one of your studies on where you worked with some folks in adult residential care? Is it the same place? Cool. I want to talk a little bit about that one a little later because it was fascinating to read. So I'm curious about some of that. But before we get into that, maybe you can tell me a little bit about. So today we're talking about Prader-Willi Syndrome. That's how we're pronouncing it.
Prader-Willi. Yeah.
So, do you have a credential with the International Behavior Analysis Organization, the Qualified Applied Behavior Analysis Credentialing Board, the Behavior Analyst Certification Board, or would like a certificate of attendance for another organization? You can earn 1.5 continuing education units by going to www.behaviorspeak.com, click on CEUs, and enter the 3 secret words. The first secret word is security. Maybe you could just start by telling us a bit about what that.
Yeah. So Prader-Willi Syndrome is a rare genetic neurodevelopmental disorder, meaning that it's genetic in nature. It occurs randomly across the population, and it seems to impact all different ethnicities equally. So essentially, it doesn't really discriminate. It's kind of a random genetic mutation, and it has a lot of neurodevelopmental features, meaning that it impacts the person's brain development, which impacts multiple bodily systems. It's fairly rare. It occurs in approximately 1 to 15 to 30,000 live births. And I think the last population incidence that they found in the United States was like 1 in every 37,000 people. The population incidences that come from the US and Canada and Europe tend to be a little bit more accurate because more people are getting diagnosed. So I would say those are more accurate than some that we find in other areas that just don't have the capacity to diagnose, because to diagnose a person, you need a genetic test, and that costs money, of course. There's different types of PWS, the subtypes rather. The first is called paternal deletion, and it occurs in about 65% of people. There's also maternal uniparental disomy, which is often just called UPD, which occurs in about 30% of people. And then there's a much more rare subtype called imprinting center defect, and that's affects between 3 and 5% of people. Most people actually in the US, interestingly, know their subtype. A lot of people in other areas do not. And there is conflicting research on how much the person's subtype impacts their symptoms, but it does appear to impact symptoms, especially like mental health symptoms, as kids get older. So there's still research that's looking into that and trying to figure out exactly what that looks like. But I think the thing that most people know right off the bat about PWS is about the hyperphagia.
Sure.
So hyperphagia is just an uncontrollable starving sensation. And if you feel like you're hungry all the time, the only thing that's kind of responsible to do is to go and to try to get food however you can. So we see a lot of food seeking and food stealing. Before there was a lot of knowledge, and still, unfortunately, but before there was a lot of knowledge of PWS, people would eat to the extent where, of course, they're morbidly obese, they have heart problems. However, people with PWS are also at risk of stomach rupture and death because they never feel full. So if you just keep eating until your stomach can no longer hold it, you can have stomach rupture, and then you can end up with death. So previously, the life expectancy of people with PWS was around 20 years old, and it still is in some countries, unfortunately. But here in the US, and for example, at the program that I worked with, when I lived there, we had somebody that was pushing 70 years old. So with proper care and supervision and support, we've been able to get people to a much more normal life expectancy and a much better quality of life. And that's the benefits of medication, but also the benefits of understanding what a healthy diet is for a person with PWS and exercise and things along those lines. And then in addition to the hyperphagia, what makes PWS even more challenging is that people with PWS have low muscle tone. So not only are they prone to being very, very hungry, but they have low muscle tone, so they tend to not burn a whole lot of calories, and they tend to be, unless they've received growth hormone from an early age, they tend to be short in stature. So it's kind of one thing piled on top of another. Yeah. And then there are a variety of other physical features of PWS that can impact behavior as well. So there's a very specific behavior phenotype that I'm sure we'll get into, but lots of other physical features like differences in brain structure and function, as well as high pain tolerance or difference in the way that they feel pain, difficulty with regulating temperature, changes in sleep patterns. So there are all kinds of other features that can impact a person's quality of life, but also can impact their behavior.
Yeah. Wow. And is it usually, I mean, at least in North America, is it usually diagnosed at an early age, or?
So we're lucky enough now that so when infants with PWS are first born, they tend to be very floppy because they have low muscle tone. So as soon as the infant is born, you can tell something's not. And they also typically very early on have failure to thrive because they're not strong enough to nurse. So a lot of times they end up needing like a nasogastral tube or something to assist with feeding, or else they just can't get the calories that they need. So there's pretty early on, it's clear that there's something is not right. And now like hospitals and physicians know enough that they will just, if they see those symptoms, they'll screen for PWS. People typically get the diagnosis in the NICU, but that has not always been the case. So we have some kids that have made it to 5, 6, 7 years old without getting a diagnosis, which is, I actually just ran into one child recently where the family had immigrated from another country and just are getting the diagnosis their child is 6. So it is possible for kids to make it to older ages, especially if they don't have as much of the low muscle tone as some other kids do. But typically right now it's caught in the NICU. Sometimes we're even catching it before. So there is an early screening for one of the types of, I think it's for UPD, I can't remember though, for one of the subtypes of PWS that you can do, I think around like 10 weeks of pregnancy when the fetus's blood starts to mix with the mother's. They can draw blood and they can test for it. And then some other early indicators of PWS are low fetal movement. So if people are saying, my baby's just not moving, I can't feel my baby, if they go to their doctor and they report this, sometimes they'll screen for PWS as well.
So what sort of things can be done? You mentioned something about growth hormone. What are some of the things that can kind of be done early on if they get that sort of early diagnosis that can maybe help things later and later?
Yeah, so the big one is growth hormone. So growth hormone helps not only with the muscle development, so we're able to help give kids to grow taller and to be strong and to be able to catch up a little bit on some of those fine and gross motor milestones. But it also helps brain development. So we have kids that are not having quite as much neurodevelopmental challenges and intellectual challenges as their older counterparts because the growth hormone helps with the development overall. And a lot of times people with PWS will start getting growth hormone very, very early and will continue to take it through their whole life. So that's one of the main supportive treatments. There are a bunch of other treatments that, for example, there's things like oxytocin that some kids receive depending on what their different challenges. But for kids, the main thing is appropriate diet and exercise, getting the therapies that they need. So speech therapy, occupational therapy, physical therapy, behavior therapy sometimes, and that they are receiving appropriate diet. So once you get the diagnosis of PWS, a lot of families are followed by a dietitian as well as a geneticist who manages the growth hormone medication. So those are kind of the main things that set kids up for success.
What do you mean by an appropriate diet? Is this just sort of a standard 4 food groups healthy diet, or is there something special about the PWS diet?
So there were a couple of slightly special things about the PWS diet, but I would argue that it's just a diet that everybody should be following.
Right. Yeah.
So, the dietitian that I follow works with one of the leading researchers and physicians in PWS, Dr. Jennifer Miller, who's in Gainesville. I follow her dietitian, who's his name's Mike Tan. The things that are different about kids with PWS are that they typically don't, first of all, need as much food. So because of the low muscle tone and because of the slow metabolism, so people with PWS are known to have a really slow GI tract. So they have delayed gastric emptying, which means that food sits in their stomach for longer. And yeah, right? And then their whole GI tract is just really slow. So that means that their body just absorbs all the calories from everything because it spends so much time moving through their body. So they tend to, on top of being hungry all the time, they tend to need less food. So portion control is a big thing, and especially teaching parents that at a younger age. And then also just a generally healthy diet. So a balanced diet that includes lots of protein, healthy carbohydrates, things like quinoa, black rice, brown rice, wild rice, etc. Those whole grains. And then healthy fats and fruits and vegetables. Fruits should be limited. I think he usually recommends 2 servings per day. Vegetables, large variety of vegetables. But I believe the recommendation now is to move towards cooked vegetables because they're a little bit easier for kids' GI tracts to process because anything that's like heavy, dense fiber is hard to break down. And then the main thing that we have learned in recent years is that kids with PWS need to stay away from eating anything sweet. So from what I understand, and I am not a doctor, so I may be saying this incorrectly.
Sure.
From what I understand, what we have learned is that kids with PWS have an overactive insulin response to the taste of sweet. So when you taste something sweet, your body releases insulin to handle the sugar. People with PWS seem to release too much insulin, and insulin is anabolic, which makes you gain weight. So that could possibly also be what's contributing to the weight gain as well. So what they recommend is that kids with PWS just don't eat sweet things, including artificial sugars or artificial sweeteners, because your body still releases insulin when you eat an artificial sweet. So that is the big thing, and that is hard to do in America. Like no sweetened drinks, no sweetened foods. That's hard for them to do.
Wow. And then of course, and the whole disorder just seems like a cruel joke, eh? I mean,
Yes.
with the hyperphagia and then everything that counters that and everything that sort of goes against that, and so now you can't have too much sugar, but if then you want to eat insatiable amounts of sugar, and it's basically going to kill you. It's just
It's not very fair, and it's further complicated by the fact that kids don't start with hyperphagia. So kids start with failure to thrive. So parents are trying so hard to get them the food that they need to get them. And then kids around the age of I'm trying to think, there's 4 phases of hyperphagia. I think typically around the age of 2 to 3 is when kids start to eat more normally. They're gaining weight, they're gaining muscle, they're kind of catching up a little bit. And then at around 8 years old, average is usually when hyperphagia starts. So there's a gap time in there where kids are feeling like they're full. So that's an even crueler joke, because
wow,
seemingly a normal development for a certain amount of time, and you're just waiting for that shoe to drop on average of 8 years old, where kids start to experience hyperphagia. Some kids in that 3 or 4 to 8 range start having an interest in food. Because their diet's different, right? So if your diet's different than your siblings and from everybody else, you notice. So it's unclear if that's the beginning of the food drive, or if it's just that kids have sorted out that things are different for them. But increased interest around food. Sometimes we will see some behaviors, for example, starting to steal food or starting to push the boundaries. And then around 8, kids hit hyperphagia. And the hyperphagia sometimes around and after 30 years old seems to improve a little bit. So that's good for adults, because sometimes we have older adults who are able to gain a little bit more independence because that hyperphagia seems to slow down a bit. But it's so hard for parents because they're trying to go from failure to thrive to be able to balance this new interest in food, but mostly things are going okay, to then all of a sudden the development of hyperphagia. So it's really not fair.
And does it improve at 30 for some folks only if they've done everything right beforehand, or does it sort of just for some reason improve when they get older for no particular reason?
I don't think that's well understood. What I will say is that the residents that I used to work with that had better habits, just from years and years and years of doing things correctly, had a much easier time. So for example, if they did experience that slowdown in hyperphagia, it was obvious, because they would say they were still doing everything they were supposed to, but all of a sudden they weren't reporting being hungry. And then it was much easier to open the door to independence and letting them cook and letting them grocery shop and everything on their own. Whereas the residents that had more problems managing their hyperphagia earlier on, we didn't see, at least from my personal experience, we didn't see as big of a change. However, it's unclear if that was behavioral or physical. So is it that you have years and years and years and years of experience of food stealing being reinforced, and therefore that behavior just continues? Or is it that your hyperphagia never really slowed down? So I don't have a clear answer on that one.
Yeah. Is hyperphagia something that's sort of exclusive to Prader-Willi, or are there other conditions where hyperphagia exists,
Yeah, that's a great question. So there are some conditions that are poorly understood that sometimes get diagnosed as PWS-like. And the reason they get that diagnosis is because if they can get a PWS-like diagnosis, they can usually get PWS-related services. So I did work with some clients that did not have a genetic diagnosis with PWS, but that clearly experienced hyperphagia. And we also sometimes see it with traumatic brain injury patients. So sometimes when we see injuries to the same parts of the brain that we see differences in people with PWS, people out of the blue develop hyperphagia. So that's where I've seen it the most, is with TBI patients or brain surgery patients, anything where your brain could be injured.
Well, and just Another question which you may not know the answer to, talked about the growth hormone and kind of how it also helped with brain development, and therefore for some folks might decrease some of the developmental delays and whatnot. Have you ever heard of folks using hormone and sort of other developmental disabilities, like in young kids, to sort of prevent delays? Because I've never heard of that until now.
No, I haven't. I think the only reason that it was originally used in PWS was because of the low muscle tone. Like that was such a clear need for the growth hormone. And then we found out what we found was that the longer and the earlier kids were on growth hormone, a lot of times the higher IQ scores they were getting. So then it's really only in the last I'd say maybe 8 to 10 years that we've developed a better understanding of people with PWS's brains. So I don't think we have the brain scan data going back for years and years before kids got growth hormone, but now we are clearly understanding that there are brain developmental differences and that the growth hormone may be the reason that kids may be having higher IQ scores after receiving growth hormone compared to their older counterparts is because of that brain development.
Wow. Okay, so we talked a lot about, there's clearly a lot of medical pieces in here. What are some of the behavioral components or the phenotype as it relates to PWS?
Yeah, so the main one, of course, that everybody knows about is food stealing. So,
Sure.
and I think part of the misconception when it comes to food stealing is that it's a choice. The one thing I like to emphasize to everyone is if your body and your brain is telling you that you are starving to death, the only biologically responsible thing is to try to get food however you have to get it. It doesn't matter how. So I think that is a common misconception, is that we can talk this person into not stealing food, or we can explain to them how dangerous it is and get them to stop stealing food. Your body's biological requirement to keep itself alive is always going to override that. So we can teach healthy habits. There's a lot we can do within behavior analysis to improve this behavior. But it's never going to be, I'm just going to talk you out of this, because the person's desire to stay alive is going to always override that. So the food stealing and the food seeking are a big one. A lot of times that can look like just over-consuming food, eating food, not wanting to stop over-consuming food to the point where it's not safe. But it also looks like negotiating with people to get food, tricking people into giving you food that you're not supposed to have, stealing food, taking food from unsafe locations like the trash, eating food that you really shouldn't be eating, like raw meat, things along those lines, and sometimes even leaving wherever your residence is or your place of supervision to go and get food from another location. Food stealing plans can get quite complicated and intense and sometimes quite hilarious. I spent a long time working with people with PWS. I one time had a client, so I used to have an office at the day program. And one time I came in early and we had this older gentleman that we worked with who we loved, and he was brilliant and he was hilarious. And I came in one morning and he'd just come back from a home visit, and they used to have some contingencies where if they maintained safe weight gain or didn't gain weight on a home visit, they could earn reinforcers. So he got a gift card because he did so well on his home visit. And he was using the gift card to pick the lock on my office to try to see what food reinforcers might be in there. And so I walked in on him doing this, and I looked at him, and I was like, really? And he's like, I have to try it. I'm like, get a gift card. So they can become the food stealing plans can be quite elaborate and hard to keep on top of. A lot of times, like a lot of people with PWS can have a good sense of humor about it. So like he was just like, yeah, I had to give it a go, and blew over, and that was fine. But sometimes depending, I think, on how a person's is raised, it can be also really like they feel so ashamed. So I try to stay away from shaming anyone about it either, because if this is something that your body is telling you to do, I'm not going to shame you for it. I'm going to try to keep you safe. I'm going to try to teach you skills. I'm going to try to do whatever I can, but I don't want there to be that like shame and guilt over it.
Right. Before we get into some of the other behavioral kind of pieces, I guess sometimes I struggle because I do see this in some of the cases we get where people call it food stealing, but it's not necessarily stealing. you're going to the fridge and you're taking food out of it. So sometimes it's just food seeking, I suppose, and stealing can be,
Separate.
one kind of aspect of that. It kind of really question, talking about the developmental delay. First off, do all folks have a developmental delay with Prader-Willi, or can some folks be fairly typical and still have all of the hyperphagia and because it sounds like you have some pretty independent folks that have jobs and the whole 9 yards. So
yeah, so I'd say that in the past, more people with PWS had what would be considered a typical intellectual disability, but a lot of times nowadays, kids are not meeting the intellectual disability requirement based on their IQ scores. However, there are a lot of learning disabilities and other cognitive deficits and executive functioning deficits that go along with PWS. So even if you have a really high IQ score, it doesn't mean that you're functioning well in other areas.
sure.
However, for example, with kids in school now, they might not be needing, based on their testing or their IQ scores or whatever, may not be needing requirements for intellectual disability and supports in that regard. However, a lot of times they'll get an other health impaired diagnosis, which is related to the PWS, and then also all the learning needs that they have. So in the traditional sense of how we used to look at it, like if your IQ score is below this, you're considered developmentally delayed. If it's not, you're not. A lot of kids with PWS won't qualify.
And with food seeking and sort of so at some point, is there at some point, so they get super hungry, they eat a lot. Is there a period where, if temporary, where they are satiated or do they just need to constantly eat?
It depends on the person. So some people will tell you, after I eat this much, I feel full, but only for a very short period of time, and then I start to feel hungry again. Other people will tell you, I never feel full. There's nothing that makes me feel full. So it seems to be a little bit person dependent.
And does the type of food sort of affect that as well? Like could if someone sort of were, taught at an early age, that they could basically just eat unlimited amounts of, romaine lettuce or something, and which I don't joke, I would eat unlimited amounts of romaine lettuce. So it's not disgusting to me. So like well, I guess kind of the question is, are there foods in a diet, and then really this might be a dietitian question, I guess, where they could just eat constantly?
So not foods that they could eat constantly, because we would still end up with the issue of stomach rupture.
Right.
However, there are definitely foods that make things better and foods that make things worse. So we know that the sugar and the sweet taste drives the hyperphagia, so it makes it worse. And we know that the things that help to balance your diet, so things like protein and healthy carbohydrates, healthy fats, things like that, help to keep people feeling full longer. So even if they never feel full 100%, at least they're not making the hyperphagia worse. So we do know, at least that the sugar makes it significantly worse.
Does this transfer to sort of other kinds of eating issues? Like I think I read somewhere that coprophagia can be a symptom. And so is that just because what does that look like? Is that because they just don't have access to food? So this is just something they can access?
So I think that coprophagia is likely to be, and this is something that's poorly understood. So I think that coprophagia, from my experience, is likely to be related to two different things. Either some type of deficit in the person's diet, where they're looking for some kind of nutrient, or it's a learned behavior. So lots of people with PWS, I won't say lots, the range of people that are said to engage in skin picking is wildly variable depending on the article that you read, going everywhere from like 40% to 100%. Lots of people engage in skin picking.
Right.
So skin picking behavior, which we can talk about later, sometimes then extends to rectal picking behavior. Part of this is that whole GI tract issue. So if a person's got constipation all the time, they're uncomfortable, you're going to try to alleviate that discomfort. And then people with PWS, as I mentioned, also have a high pain tolerance. So you're not getting that pain feedback from your body saying, stop, that hurts. And then recently, I was actually listening to a talk at the last PWS conference by a GI doctor, Dr. Ann Scheinen, I think her name is. And she's amazing. But she was saying that we have recently discovered that the GI tracts of people with PWS excrete an itchy substance. So it's a combination of itchiness, GI discomfort, and probably, like lots of people with developmental disabilities, especially with fine motor and gross motor deficits, hygiene is not necessarily appropriate. So we have additional discomfort and itchiness. So sometimes that results in rectal picking. And then I think that a lot of times the amount of attention that we start paying to the person's bathroom use in general goes way up. Yeah. So we then risk potentially reinforcing the person coming up with more creative behaviors like coprophagia, to either because it's reinforcing for some reason or because their parents are freaking out or whatever the situation is. But I do think I have seen two different, like, distinct situations with coprophagia. One does seem to be either that it's automatically reinforcing or the person is missing something in their diet. The other one is definitely, I'm doing this for attention. So I think there are two clear functions there depending on what the person's history is. I would say the older adults tended more towards something missing in my diet, and the younger kids I'm seeing now are tending more towards attention maintained. So it's not just coprophagia, it's also smearing on the walls or doing something to try to stop me from going back to class, et cetera, et cetera. So that to me looks more like learned behavior.
And then kind of related to that, do folks with PWS have a higher likelihood or tend to also, just because I'm thinking about sort of the point around maybe missing nutrients and whatnot, engage in pica behavior?
So funnily enough, it's not significantly higher in in people with PWS. I will say that maybe what we consider to be inedible objects is higher likelihood of eating. And I will say that they'll give things a try. Like, I had another gentleman that lived in one of my residences who I also loved down to the ground. And he, one time, his staff brought him to me and thought he had an illness because his lips and his tongue were black. And she's like, Kasey, I think we have to take him to the nurse. I don't know what's going on. And we had an on-site nurse, which was great.
Sure.
And I'm looking at it, and I'm like, did you look at a marker? And he looks at me and he goes, it was grape scented. So it had been a grape scented marker.
Right.
The marker to see if it tasted like grape. So stuff like that. But he never did it again. As soon as he established the marker did not taste like grape, he never did it again. So we did have some people that we were a little bit concerned about pica because they would pick things up off the floor and we didn't always know what they were eating. But usually I've not seen too many true cases of pica. It's more a case of mistaken identity, like I thought that was food and it wasn't food. One of our residents has had a bowl of fake apples on the table.
No.
Bite marks. But where I have seen something that is closer to true pica is, in addition to, like, kind of part of the skin picking or the body focused repetitive behaviors, is there's some kids that will pull their hair. I'm not going to try to say trichotillomania. I always say that.
You did it right. Yeah.
I did. First try. And then also who also sometimes had like a sensory attraction to hair anyway. So dog hair off the floor, horse hair, anything you can come up with. And they would ball it up and sometimes eat it. And so the hair eating I've seen significantly more than what I would consider any kind of true pica. And of course, that's also very dangerous if you cannot process the food through your stomach. So that is one area where I've seen it.
Yeah. Wow. Okay. So hyperphagia is a big one. The second secret word is genetic. You talked about skin picking, so let's talk about skin picking. So is skin picking pretty common with PWS, and is that, and how does that sort of manifest? Does that start pretty early too, or?
Yeah, so I think it's a little difficult when kids are younger to tease out what is true skin picking and what is just a kid being a kid, because kids will pick their scabs. That's just what they do. And the difference is for like a kid with PWS, they will stop when it hurts. Kids with PWS don't get that pain feedback. So all they're getting is whatever the automatic reinforcement is surrounding the picking behavior. So making the itchiness or the discomfort stop, getting the endorphins or whatever your body is releasing related to the injury. However, I also think there is potential for parents to shape skin picking behavior, because I have seen situations where parents were really overreactive to picking cuticles or picking lips or picking scabs. Where I kind of draw the boundary is if if it's passing the point where wounds are not healing. So if your child with PWS picks their cuticles or their lips and then they leave it alone, or if they pick a scab off and then they leave it alone and it heals, I wouldn't consider that to be skin picking. I'd consider that to be okay. However, if we're getting to the point where you're having to go to the doctor because things aren't healing, that to me is verging into skin picking. Unfortunately, kids learn really early that it drives their parents ballistic and that it gets them out of class because you can't have bloodborne pathogen risks. So I think there's definitely a learned component in addition to the clear automatic function. With my adults, skin picking can be really, really severe. So with older adults, we were seeing picking behavior that ranged from same thing, just like picking scabs. Maybe we have something we have to clear up once in a while, to people that had put themselves in the hospital because they had picked down to the bone. Like wounds that you could not get to heal for years. People with chunks of muscle missing and chunks of underlying fat missing because they picked up an area for so long. So really, really bad, scary wounds. However, it does respond to behavioral interventions. So we had all kinds of behavioral interventions for for our adults. And we were able to make a big impact on the skin picking. So it definitely, that's the good news, is that yes, there is a huge automatic component there, but it definitely responds to intervention.
And were some of those interventions similar to the skin picking interventions we've seen in folks without PWS? Like I'm thinking of I had Doug Woods on the podcast a while back. He was talking about what's just the intervention, the habit one.
Habit reversal.
Thank you. Yeah.
Yeah, I know what you're talking about. I approach it differently. I've never tried a habit reversal technique with people with PWS because a lot of I think part of the assumption of a habit reversal is that you're doing it without knowing it. I think a lot of people with PWS know exactly what they're doing. They're paying attention to what they're doing. So it's not so much that I need to bring your attention to this and teach you to stop. For what I focus more on is wound care and bandage compliance. So if your wound is covered, you can't pick it. You can't pick it unintentionally, but you also can't pick it intentionally. So I would usually do some type of reinforcement system that was focused on the person getting appropriate wound care, getting their wounds bandaged, keeping those bandages on until the next appropriate time to change the bandage, so that there was just a physical block in between.
Yeah.
And then also a component of reducing the number of open wounds that you have per day. So doing a wound check, if it looks like they're healing, you're earning your reinforcer. If you clearly picked it, we're not earning a reinforcer. More focused on those incompatible behaviors versus what I noticed at least was that if the wound was uncovered, it was going to get picked. Accidentally, on purpose, something. But if we could get that barrier between and we could get people tolerating those bandages, that's when we would start to make progress.
No, that seems kind of brilliant. I mean, just good old response blocking, and if there's a bandage in the way. And did you find when you were doing that kind of work with the bandaging and the wound care that folks would just go pick somewhere else?
Not usually, because then that would count as another wound that they would then have to get bandaged. So, and a lot of times people with PWS have preferred spots. So if you could keep those areas covered, and a lot of times those preferred spots are obviously what's easily accessible. So arms and hands and scalp and things like that, but also old locations. So I don't know if you've ever had a significant wound or scar or something. It stays itchy for a really, really, really long time. So making sure that for example, I usually recommend aquifer wound ointment to just keep it moist constantly until the itching is no longer there. Because I think sometimes the itching is what prompts it. But if the people I was working with weren't going and looking for other locations, they were really excited about the reinforcement contingencies. So we didn't typically have the problem of whack-a-mole, we covered one, now we gotta cover this other one.
So full disclosure, I ask a lot of these questions because I've had a skin picking problem all my life. Since I was a young child. I think I started when I was 5, and don't worry, I'm not looking for therapy today, but I picked, kind of like said, I have memories of my mom saying, don't pick when I was 5 and 6 years old, getting that attention. But I also had And I've been really open about this on the podcast and in my life, and so I don't mind talking about it. But I also had like some OCD tendencies. This all kind of came to a head when I got an ADHD diagnosis in the last 5 years. So this is recent, got some medication, and it got rid of I think a lot of the underlying mental health issues, anxiety and OCD primarily. But it was, I don't agree. I was the same. I knew what I was doing. I wasn't like, doing something else while it was happening. I was well aware it was ritualistic behavior. Granted, I had a regular pain tolerance, so I didn't, have the kind of wounds you're talking about. Like I was blown away when you said they actually can pick down to the muscle and the fat and the bone. That's wild. I couldn't imagine, being able to do that. As soon as it, became painful, I would stop. But things I would do when I was younger was, I would, because I think there was a sensory component as well for me. And so I would move to areas where people I would try to move into areas where people couldn't see. And so I was curious if sort of folks would, they're picking the fingers and the scalp and whatever, would they move it to sort of, areas that you couldn't visually see right away? Like, were you doing like full body inspections, like naked kind of thing, or probably not?
Not usually. However, staff members were pretty good at keeping an eye on clients and making sure, for example, when they took a shower or something, just like being aware of clients and what was going on. We weren't doing full body checks because typically we didn't need to. We had where we would run into a problem where we would need to do a more extensive body check is if somebody had a lot of skin folds. So if they lost a lot of weight and they had a lot of skin folds, sometimes we would get irritation between their skin folds, which would result in picking. But it wasn't usually that they were going to their skin folds to hide the picking. It was that they were not taking appropriate care of their skin folds, and so they were getting skin breakdown, which was relating to picking, or was leading to picking. I think I can't really tell you why we weren't having that problem, but I do think it's because there was an attention component to the picking. So they wanted to pick places where people could see. The resident that I was telling you about, that were one of the residents that had skin picking down to the bone, he had a wound that he would continually open up right before a PWS conference, because he knew he would have to go with a huge bandage and everyone would make a big deal of it. And then he would go the rest of the year. And then for his PWS conference, he would open it back up again. So I think there was a component.
Did he stop going to the conference?
No, we put some reinforcement contingencies in place and we dealt with that. We told him, like, if you want to just bandage up your arm and go to the conference, we're fine with that. Just don't pick your skin.
Yeah, the bandage, and again, the bandage thing was what worked for me. So because I tried sort of the habit reversal kind of stuff, and I think because I had undiagnosed and unmedicated ADHD, I was too distracted to sort of follow through with any program, and just quickly distracted by everything else, and then would kind of move on. As soon as I got into bandages, and I found these bandages, and this is, we talked about pronouncing words properly. There's bandages now. There's some newer ones called hydrocolloid or something like that bandage.
Yes. Yeah.
You know what I'm talking about? I think they market them for acne more so, but they heal. They both, two things. One, they look like skin. They're a lot less obvious, and they're meant to be left on for a week or two at a time. And they're magic. Like, leave them on for a week, peel them off, it's gone. They're super healers. They heal 2-3 times faster than a regular Band-Aid. That's a trick.
Not actually. Yeah, I'm gonna check that out. What was it called?
I'll share the link with you. I get them off Amazon, and they're glorious. So recently I had
try that.
Recently I had one where it was one where I didn't realize. I thought I was just picking a tiny scab, and then I was just itchy, and then I looked at it in the mirror and I went, "Oh my god, this thing's gaping." I had no idea I had picked it that much, and so I put one of these bandages on, and a week later it's gone, completely cleared. I felt like it was a bit magic in some way. So there are some cool technologies out there, I think, now too for that sort of thing. But you're right, the response blocking was awesome. I was like, oh, why didn't I think of this 30 years ago? I'm putting creams on, I'm trying different things, I'm trying to, I'm wearing long sleeves, but put a Band-Aid on and suddenly, it solves the problem. So
yep.
Yeah, really.
One of the simplest explanations you just don't think of for years and years, and then you're like, why didn't I think of that?
Well, I think to your point also, though, it's not just wearing a Band-Aid. It's also all the, you had all the reinforcement strategies around it. You were reinforcing Band-Aid wearing, you were reinforcing wound care, wound cleaning, probably all those kinds of things, and kind of putting folks into pretty good habits. Is there any, I suppose there's no real idea on either for the hyperphagia or the skin picking on what sort of the initial cause is. I mean, I guess the low pain tolerance is something, and then the attention, but I guess folks don't really know beyond that what kind of causes these crazy symptoms.
I think a lot of the behaviors, as well as the hyperphagia, we know come from, at least partially, from those brain differences. Right. So I guess I can talk a little bit about that first, and then I can talk about some of the kind of the other theories. But there were some really interesting studies. There was a study done with, I think it was with kids and adults. I think it was like 13 to 50 years old or something along those lines. And they split them up into, they had a couple of groups. They had a group with PWS that in that age range, they had a matched control group of the same age. And then they had a matched control group with obesity. So they wanted to look at the brain differences for the PWS condition and also to find out if obesity had anything to do with those brain differences. And the results showed no difference between the obese group without PWS and the typical weight group without PWS. But for people with PWS, there were several brain regions that were significantly smaller. So these included, if I really hope I get this right, never had this memorized off the top of my head, but the thalamus, which is responsible for sensory processing. So things like pain, and then also the amygdala, which plays a huge role in regulating emotions, which we can talk about later with some of the tantrum behaviors. And then also some structures it was also the hypothalamus, something else in the frontal lobe, and the brainstem structures. And the structures in the brainstem are really responsible for regulating bodily functions. So all of these areas we think are possibly responsible for hyperphagia. So if you're not monitoring your bodily functions correctly, also if sensory sensations are different, you may not be getting that feedback from the stomach to the brain that you're full. And then also if you're not getting that pain sensation, you are not necessarily going to stop skin picking. But these areas of the brain are also responsible for things like executive functioning. So executive functioning skills, in addition to emotional regulation, are like planning, understanding abstract concepts, transitioning, all these other skills that we know are a challenge for kids with PWS. So for people with PWS, the more I learn about the brain differences in people with PWS, the more it makes sense to me. Like these areas of the brain are also responsible for things like sleep, which we know is highly disruptive for kids, for people with PWS. Also, temperature control is difficult for some people with PWS. And so it just kind of all fits, like the medical part just makes all the behavioral pieces kind of come together. So that is part of what we do know about hyperphagia. But the exact mechanism of the hyperphagia is still not well understood. And I think that's why they have not been able to develop any medications that really impact the hyperphagia. There are some that are in clinical trials right now that are looking promising, but there's not anything that's available on the market that really helps because I think we're still figuring that out.
Yeah. Okay, well, what are some of the other, so skin picking, hyperphagia, what are some of the other kind of behavioral components of PWS we need to think about?
So the one that I think actually, especially with parents in the US now who, like parents of younger kids now, have a pretty good handle on the diet, which I think is amazing. So they have a handle on the diet, and they also have a handle on the like requirements around food security. So the thing that I think they're actually struggling with the most is the emotional dysregulation. I mean, we typically in ABA call that tantrum behavior or something along those lines. And that can be everything from yelling, screaming, crying, all the way up through aggression, property destruction, self-injurious behavior, eloping from the home. So there's a whole range of behaviors that can occur in there. What is notable about emotional regulation issues in people with PWS is that something that seems like a very small trigger results in a huge emotional reaction. And people with PWS tend to go from 0 to 100 really fast. So there's almost no time to stop, prompt functional communication, try to problem solve with you. It's like this happened and all of a sudden you're all the way up here.
Wow.
And then it also takes them a very long time to calm themselves down. So that ability to de-escalate is significantly impacted probably by those brain differences. Part of your brain is responsible for emotional regulation. So that makes it really challenging for parents and really challenging, especially for adults who have not had the benefit of some of the knowledge and therapies that we have now, because anything that seems like a small trigger can result in a very, very, very big and dangerous behavior. So I think that is one of the areas where we're struggling with the most now.
So what are some of the things we can do?
So my whole quest as a person right now is to try to figure out how to effectively teach emotional regulation skills. And that sounds very on-behavior analytic. And I realize that, and I haven't come up with a good way to put it in behavior analytic terms yet. And this is, so we actually have some grant funding for a project over the next year in 2025 to really do a deep dive into how behavior analysts teach emotional regulation, educators teach emotional regulation, and also other people teach, like people who work on mindfulness and meditation, how they teach emotional regulation and what this really looks like. What I look at it like a skill deficit. So every tantrum that occurs in PWS, I don't look at it like you're doing this on purpose because you're not getting what you want. For me, it's like, oh, your brain's fight or flight has taken over and you don't know how to regulate yourself. So the way that I currently teach it is a combination of teaching and mostly focusing on teaching an incompatible behavior, but sometimes also an alternative behavior. I think what's a struggle for teaching kids with PWS, especially in the school setting, is that we always teach preventative strategies. So let me do zones of regulation with you. Let me help you problem solve. Let me help you communicate. But if you're going from 0 to 100 in 0.2 seconds, that doesn't really help you. And what typically happens after that is kids have a tantrum, they get punished for it, and it just goes downhill from there. So I try to teach it both at the prevention side and after the tantrum. So I will try to teach you all those strategies to prevent, whether they're incompatible behaviors like breathing or walking, or even something that's just an alternative like coloring that's not necessarily incompatible but maybe soothing in some way. And I let kids pick their own behaviors, because PWS kids are pretty good at figuring out, oh, this is soothing for me, I like to do this. So I let them pick their own behaviors. But then we also have a step-by-step plan that I call it like a self-calming protocol, because I don't know what else to call it. But it's like, we will try to get you to functionally use your functional communication. We will try to get you to work on your incompatible or alternative behaviors. But once you hit that point of no return, and we all know what that point of no return is, where when you get past that, you're not learning, your brain's off. You're in fight or flight mode, your brain's not working. Where I'm teaching parents how to, it's not really planned ignoring, it's more minimize their reaction to not make it worse. So, because parents will continue to negotiate and try to figure out what to do in that moment, and that doesn't help. For people with PWS, that just continues to escalate. So teaching parents where to draw the limit and step away, and give their kids the opportunity to try to self-regulate instead of parents trying to co-regulate with them. Because sometimes the co-regulation strategies make things wildly worse. As long as kids are safe, and we usually have a location that's a safe location, like a beanbag chair in the corner of their room, something like that they can go to. We give them space to figure it out. And then when they start to de-escalate and they go back down past that point of no return, that's when we would prompt additional practice of those calming strategies. So, okay, you've started to de-escalate. Let's sit together and take some deep breaths, or let's go for a walk, whatever the safe activity is, so that the parents have the opportunity to prompt an appropriate behavior and reinforce it. So what happens a lot of times with anyone's tantrums is that parents negotiate whatever in the midst of the tantrum. There's lots of attention. Kids get reinforced for that. So trying to minimize the attention to that, but still give kids the opportunity to show something appropriate and get reinforced for it. Every person with PWS calms down eventually. Nobody stays escalated forever. You would die. It's not possible.
Mhm.
They figure it out, right? They do
Mhm.
something appropriate at the end of
Mhm.
that tantrum, and we don't pay any attention to it. All we have to do is differentially reinforce whatever they have figured out how to do.
Sure. Yeah.
What tends to happen is not that people magically figure out how to prevent their tantrums, it's that the duration gets gradually shorter. So the duration gets shorter and shorter as when they get differentially reinforced for that calming process, whatever it is, they get better at it because they're paying attention to it and they're trying. And then the tantrums get shorter and eventually they learn how to prevent. So I just worked through this whole process with a kid. He's 10 years old. He was having pretty significant, like over an hour tantrums several times a week. And so we taught him this whole procedure. It's been like maybe 4 or 5 months since I talked to the parents because they were part of a research study that we were doing. But I checked in with her just on another issue. And in the course of the call, he got upset about something that he couldn't have. So she prompted the communication. He said what he wanted. He couldn't have it. She let him know. He went to his room. He calmed himself down. Took him 3 minutes. He came back completely ready. So it's not that the trigger in the tantrum itself magically goes away. It's the impact on people's lives.
Does the behavior they choose for regulation sometimes end up being the skin picking?
Sometimes, but we'll typically have a competing contingency for kids that go to skin picking. We definitely see an increase in skin picking when kids are having a tantrum. I think that's probably both regulatory, so trying to regulate in some way, and also that they know it makes their parents nuts. So if I'm really upset with you and I'm trying to make you crazy, I'm going to go to whatever is going to make you crazy. So we try to offer a lot of alternatives that are similar to skin picking, like behaviors that are for maybe scratch that picking itch, so to speak, like putting glue on a piece of plastic and letting kids pick it off. Or I have some kids that like to highlight. I have some kids that like to shred, like take apart, like if you took a washcloth and you cut the end off of it, they like to shred that. Or like to take the seeds out of things, anything like that we can reinforce instead. But we usually treat it separately. If your main problem right now, if you're picking and you're smearing blood around, but nobody's dying, it's not a huge wound, it's just gross. Okay, fine. We're going to focus on the self-calming first. We're going to ignore the picking. We're going to focus on the self-calming first.
Right.
Because when you start to reinforce the appropriate behaviors with self-calming, the skin picking goes away.
Gotcha. Yeah. Okay, no, that makes sense. Cool. All right, let's talk about. So you said you had some folks involved in some parent training. Tell me a little bit about this parent training study you did.
Yeah. Okay. So we're up to 3 parent training studies now.
Okay.
We had the first grant that I received was a grant from PWSA USA. That if anybody out there listening needs information on PWS, they're a wonderful organization. Their CEO is a BCBA right now, so that's amazing. Yeah. So they're really supportive of all the behavior analytic research, and they do really amazing work. But they gave us a grant to develop a remote parent training program that was specific for kids with PWS and covered all the typical PWS behaviors. So we talked about some of them, but in addition, there's a lot of like repetitive behaviors, repetitive verbal behavior like asking and telling, repetitive play, rigid behaviors, which of course, if you have executive functioning deficits, change is hard. So you randomly changed up my schedule, that's not going to work for me. Refusal, so not wanting to start tasks is a big problem for kids that parents report as well. Because, of course, if you have low muscle tone and daytime sleepiness and motor planning issues, the motivation to do things is a little bit lower. So we wanted to develop a parent training that was focused on all of those concerns. And so it took me about a year, and I did like a lit review of all the existing autism-focused programs, parent training programs, like the Ruby Parent Training Manual and all those other ones that are out there. And we kind of accumulated a list of the common strategies that were put into those. And then we wrote a program. I say me, but I wrote a program that took all those strategies and focused them on PWS-specific problems. And so it's called PWS Smart Start. It's a 13 module program, and it goes over everything from how to track behavior data, how to take ABC data, how to figure out function, all the way through things like self-calming, dealing with food stealing strategies, how to teach skills in a way that is effective for kids with PWS. So we tried to really cover everything. And then in our first study, we had 30 parents, 35 parents who participated. We ran it just as a pre-test, post-test group design. We had parents collect data, but we didn't have, for many families, we didn't have a second observer. So that's not data that we could publish. So we just looked at the change from pre-test to post-test, and we got really good results. So not only were parents reporting significant reductions on the behaviors that they were concerned about, they were also reporting big increases in skills and overall like secondary outcomes, like reductions in parental stress, increases in positive parenting practices, and in like overall family functioning. So that was really cool. So we went back, but we all know like pre-test, post-test design is not ideal, obviously. So we went back to another PWS organization, the Foundation for Prader-Willi Research, that is more of a research-focused organization. And we applied for another grant, and we wanted to do a randomized control trial. So one of the challenges of doing ABA research in the PWS field is that the rest of the PWS field speaks medical language. They don't speak single subject language. So if you're going to get any recognition for the work that you're doing, a lot of times you need to do a group design and you need to talk to them in statistics. Because if I'm talking to you about visual analysis of a graph, it's not going to land. So we ended up landing on doing a randomized control trial that we have just wrapped up like 2 months ago. And we had 2 groups of about 30 families. We put the first group through the parent training program. We had a waitlist control group. Then we put the second group through the parent training program. We're going to look at all those outcomes. So I don't have those data yet. I only have the data that the parents collected by themselves through the course of the program. But that data is showing really good outcomes so far. So we'll have to do all our stats and I'll keep you updated on that. But those are the 2 big, like main parent training ones. And then we did a smaller one that was focused on skin picking. So this one, I think we had 12 participants in this one. And we did a single subject design for this one, where our primary outcome measure was that parents were sending weekly photographs of their kids' wounds. So we could count the number of wounds and we could also grade whether or not the wounds were healing. So we got a permanent product outcome. And then we did not want parents sitting there and tallying every time they're skin picking. So we had them do a daily rating scale where they were just rating, are things getting worse or better? And then we turned that into numerical data that we could graph, which is not something I've ever done before. It worked out really well. It was kind of a secondary outcome that we were looking at and kind of a long shot, but it ended up turning out well. And we were focusing on an intervention package that included teaching functional communication training. So getting kids to either request what they wanted or to request an alternative or incompatible behavior. And then that whole bandaging protocol that I talked about. So differentially reinforcing, keeping the Band-Aids on. And we got really good results from that as well. So we had some kids that didn't show too much of an outcome because they didn't really have too many wounds to start with, which was also interesting information. And then like they didn't have too many wounds to start with or finish with. So it's parent observation of the picking behavior that was the problem. So it was the parent's reaction versus the actual like damage. For the kids that did have significant wounds, we saw a reduction in the number of wounds as well as in the severity across the course of the program, and significant improvements in the caregiver ratings that lined up pretty much exactly with the changes we were seeing.
Right. So those kids weren't picking a lot. It had a lot of sort of social validity for the parents.
Yeah.
And so what was that secondary rating? Was it literally just how was your day, or what was the question?
So we used kind of like an ecological momentary assessment format where we sent to the parents. We did it once a day in the skin picking one. In this recent research study that we just did, the randomized control trial, we did a small group of more single subject data that was using ecological momentary assessment that prompted them to fill out the frequency and severity of their child's problem behavior through certain times throughout the day. So that's what I was talking about.
I see.
For the skin picking one, we just sent out a text message to them once a day and said, please, do you feel that your child's skin picking was better, the same, or worse than yesterday?
Okay, yeah.
And then we just asked them to report on the number of wounds that their child. And that was it. Yeah, it's kind of, it's hard when you work with a population that's spread out all over the world. It's not like I can get in-person people to do research studies with. Like, we have participants in this last study, we had participants all the way from like US and Canada, which is to be expected, to Qatar, to India, to spread out all over the place.
Oh, interesting, yeah.
Single subject, it's a little hard sometimes, so we have to get a bit creative.
Yeah. Really neat. Really cool that you had folks from all over the world. That's just nice for that, that the outcomes are, and it also speaks to your point, I think, way back that Prader-Willi doesn't really discriminate based on sort of culture or ethnicity or identity or whatnot. It's just has to be the same in everybody.
And sometimes it's even more important to get make research studies available for countries that don't have anything. Because some countries don't even have behavior analysis. So these parents are doing the best they can with absolutely nothing.
Yeah. No, I know that. I've interviewed a lot of behavior analysts who are the only one in their nation. So yeah, accessing service is so difficult for sure. Okay, I'd like to hear about the study and a little more about the work you were doing in the residential settings, because I know that's where we talked sort of outside of the podcast with a couple of my folks that are kind of working in kind of residential care settings. And this is something I think a lot of us run into where, especially older adults with Prader-Willi who never had any kind of early intervention, potentially never had, any, access to diagnosis and whatnot, and are really just dealing with sort of, decades of poor learning histories and reinforcement for a lot of these challenges. And now they're in these, group homes or hospitals or whatever settings. And really, it's just usually in highly restrictive environments, everything is locked, the kitchen is locked, all the rooms are locked, and community access is limited because it's safer. And, and I think a lot of people are struggling in those contexts in terms of what to do. So I'd love to hear about some of the research and work you've been doing in adult settings and successes you've had.
So this study was I think the first thing I ever got published. So it's really exciting. And it was what happened was after I had left this place where we did I think we say where we did the research.
Yeah.
Okay, yeah. So the Arc of Alachua is where I was working, and the Arc of Alachua is a nonprofit that I have been speaking about. And so once I left the Arc, they allowed me to come back and do an archival study because we wanted, looking at our behavior plans and looking at our annual data and everything. We're like, I think we're doing a pretty good job. So we wanted to do a big picture look at it over the course of many years versus just 1 year. So we pulled all the data. We had some inclusion criteria, including how long the person had been in the program. They needed to be engaging in behaviors, et cetera, et cetera. And then we pulled the data from 43 people with PWS over the course of 6 years. And we looked at essentially just the reduction in all the different skills, or in all the different behaviors, rather. So the first part of that article is kind of describing the PWS protocol that exists at the ARC. That is the work of many, 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 many behavior analysts over many years. And the person who really pulled that kind of all of that together and created a PWS protocol was the owner of the company, the ABA company, Mark Lister. And so he really led the charge on, let's get this down as a protocol. Because what we're doing, generally speaking, yes, our plans are individualized for everyone, but there is a main protocol of what we're doing, and it's working really well. So we kind of wrote up that protocol, and then we pulled all the data, and we looked at the results over time. So, of course, it's an archival study, so we're making assumptions about functional control, but you can't say for sure because it's all archival data. But
sure,
we found statistically significant reductions across pretty much all the behaviors where we had a large enough sample size to see a statistically significant reduction. And then we had some behaviors that were a little bit less common, like coprophagia, rumination, rectal picking, things along those lines, where we saw clinically significant reductions, but we didn't have a large enough sample size to be able to really run any stats on that. So I thought it was a really nice way to validate the work that the program was doing. And what's different about the ARCS program compared to what we often recommend for like kids with PWS is that we were using a huge token system that was based on calories.
Mm-hmm.
So each person had like a physician required base allotment of calories that they had to eat with nutritional requirements to make sure everybody was getting what they needed to get. However, they would have opportunities to earn additional ones. So, for example, if they did exercise, they would get to earn some additional calories. Or if they had, for most people, if they had a really like severe concerning behavior that we were working on, if they engaged in the alternative behavior, or if the person had a DRO system, they'd have the opportunities to earn some extra calories. This is small. We're talking small, like 10 calories, not huge amounts of calories.
Right.
With the exception of exercise. So if you're doing your exercise, you could be earning 50 to 100 extra calories for whatever exercise you're doing, because that's something we really wanted to focus on, is getting people to do their physician prescribed exercise, because it's just so important. But yeah, so we had lots of other reinforcement contingencies in place, and some people did not do so well with the calorie system, so we switched them onto something that was not related to calories. So everyone's plan was individualized, but for the majority of people, it worked really well and they really liked it. So that's kind of was the basis of the program.
Yeah. And then what were some of the other kind of environmental things like in the homes or in the residence that sort of made this all work?
So we had a huge focus on food security, of course, in the homes. So some homes we were lucky enough to get funding to build specifically for people with PWS. So one of the kind of counterintuitive things, like we think of food security as really is really restrictive. Like that's most restrictive environment. But if you talk to people with PWS, they will tell you that when they're in a food secure environment, it gives their brain space to think about other things. So they'll say like I run a PWS lab at the Chicago school. And so I had a bunch of my adults that I used to work with come and talk to the lab so that you tell us what you want research. You tell us how this feels for you. So it's not just us making up things as we go along.
Yeah.
And so we talked about the hyperphagia, and all of our the residents said, if the kitchen is locked, I don't have to think about it. I can hang out with my friends. I can do whatever I want. I don't have to think about it. But if I know something is available for me to steal, it consumes my whole brain. And I'll do lots of things to distract myself. I'll do crossword puzzles. I'll do all kinds of other stuff. But my brain can't get off of it. So we kind of approached it, having heard that from our residents, we approached it from the perspective of food security actually gives freedom to people with PWS. So we tried to build homes with that in mind if we could. So we would build a kitchen that had a physical door, that when it's not mealtime, we could just lock the door and we don't even have to worry about it. Other homes that we did not build, that either the program bought or was renting, we had to do all kinds of exciting things with alarms and things like that to make sure that the kitchen was secured. And then we had a big push, which I think was really effective, at the day program to get the day program to be secured as well. So because there were vending machines, there were other stuff for other clients and residents, and there was snack time and mealtime and everything else. But most of the time it was people either working or learning or doing some kind of community inclusion. So there didn't need to be food around all the time. So we just made a big push for everyone to kind of check their lunches in and check their lunches out, and just having vending machines used at times that were supervised. And that helped a ton, because then just the level of anxiety in our PWS residents went down significantly. So that was one of the main things that was present at the home. And then, of course, staff supervision. So depending on the person's level of need, they might have 24-hour supervision, or they might have supervision just in meal times or whatever it was that they needed. So those were some of the big things that we kept an eye on.
That really makes you think a lot. I mean, it's the whole concept of restriction being, calming. It almost seems to be like the locked fridge worked just like the Band-Aid.
Yep.
And just allowed them to sort of focus on kind of other things. Because it just makes me think more about sort of the bigger sort of I guess, ideological arguments about restrictive practices, and really, and maybe the biases that are kind of in place when you're thinking about those things. I mean, generally speaking, yeah, I think folks should have as much freedom as they can possibly have. But if freedom actually leads to more stress and anxiety and pain, then is putting a restriction in really, a restriction.
Right.
Yeah.
Like,
Interesting.
is it, sometimes I wonder, I think we try too hard to shape people to the world instead of
Yes.
shaping the world to them. And
Yeah.
maybe what our older adults with PWS need is a world that's shaped for them, a place that
Yes.
they can excel, they can work, they can learn without having to think about food 24/7. Because if you think about, like, the best thing I can compare it to is like somebody that struggles with alcoholism. Are you going to march them into every single bar and be like, so how are you going to do in this one? So how are you going to do in this one? Alcohol's everywhere. You have to deal with it.
Yeah.
No, you're not. You're going to teach them to stay out of bars. So for me, it's the same thing. If a person is not struggling with hyperphagia too much, they're not too anxious. Yeah. Let them do whatever they can handle within safe means, obviously. Like, let them work independently, let them cook independently. I had a resident who wrote a PWS safe cookbook. Like, she just made all her own recipes. She did the cooking for the house. So I am by no means saying restrict people where they don't need to be restricted. But if that restriction gives you the space to breathe, then that's maybe where you need to be at that moment until, fingers crossed, we get a medication to control the hyperphagia and we can really open the doors up for people.
I'm curious, and this would be more anecdotal, I think, but how, when you had folks in these programs and you had the restrictions and you had the calorie things and whatnot, but then they were also still going into the community and maybe going to jobs, maybe doing other things. How did that play out when they were outside of the environment that you had to control over?
The third secret word is strategies.
So if it was some of our residents that struggled more with food stealing, they would always be going with staff members. So we would make sure that they had staff to supervise them, community, whatever they were doing, work. However, we did have some residents that went to work on their own, that took the city bus, went to work on their own. We monitored their exercise. For some people, we also monitored kind of their meal planning to make sure everything was according to plan, and their weight. And as long as weight wasn't going up, we let them be.
Right. And because this is almost like interesting that this could almost be like a job accommodation for someone with PWS. Like, I have a job, I want to go to this place, but I need you to lock the fridge, kind of thing. Had you seen any of that, or?
So we did have some locations that were pretty open to that were either volunteer or work locations that were open to helping to secure the environments. Like, for example, we had some residents that volunteered at the animal services, like the Humane Society, and they were really good about those kinds of things. Other places are just not a good fit. Like, we had some people that were we didn't have any PWS clients, but some other clients that were going to work at the grocery store. Just not a good fit.
Yeah.
But I think the community was really pretty open and supportive of our clients, and we were lucky enough to be able to get the resources for people to go and do their jobs and have supervision if they needed it. So it wasn't too much of a problem for us, but the ARC itself also offered a lot of work positions to residents. We had like a secure paper shredding department. We had a whole bunch of different things that the ARC built for different, well, they were, like, I can't even remember, tubing and all kinds of different stuff that they built. They put packages for different stuff. So there was a lot of on-site work opportunities as well for residents that couldn't go to community jobs.
One question that I forgot to ask kind of earlier around kind of early intervention. So you talked about, starting early around, diet planning and exercise and building muscle tone and kind of all those sorts of things. With the whole hyperphagia kind of coming onset around, 7, 8, 9 years old, what were some of the things you were able to do or you can do to sort of help these kids prepare for that?
I think it's often more about helping parents put structure in place early. Because when I noticed kids struggling the most is when it was like no food security, and then you hit hyperphagia, and all of a sudden we're locking everything up. You can't have any.
I see, yes.
So it's more about putting the putting the structure in place from when kids are really little. I'm a big fan of both putting structure in place and teaching appropriate skills. So if your kid can handle it, I want them to learn how to measure food. I want you to teach them what a healthy diet is. I want them to know what is safe for them to eat. If they're a little bit older, teach them to make a sandwich, teach them to make an egg, teach them the skills that they need to understand what is safe and what is not safe for them, but also have some general requirements in place. Like if you're going to go into the kitchen, you need to ask first, you need to wait for supervision. If I'm giving you the freedom to get your own snack, you need to pick one of your PWS safe snacks, you need to measure it appropriately. So putting those boundaries in place. And then the way I usually families, boundaries in place before, so it's not a big change. And then I also usually try to encourage families to I'm not really a fan of lock everything up if you don't need to lock everything up. Like if your kid's not anxious about food, if they're showing some food stealing, some symptoms of hyperphagia, but they never take anything out of your kitchen, don't lock it up. Like don't go crazy locking things up that don't need to be locked up. So I'm a big fan of using a motion activated camera around the time that we get a little worried about hyperphagia so that we can monitor if food stealing is actually occurring. Because I've had circumstances with kids, for example, that only stole peanut butter and their PWS safe snacks. That was it. There was bread on the counter, bananas on the counter, the refrigerator was open. She would ever steal was her PWS safe snacks that were in the same cupboard as hers and her brother's, but she knew what was hers. And people with PWS are very rule governed. So if it's like the rule has been I only eat my PWS safe snacks for my whole entire life, there's a good chance that even if I'm experiencing hyperphagia, I'm not going to deviate from that. So what we had to lock up in her kitchen was we had to put the peanut butter in the cabinet and lock that up. And that was it. And nothing else needed to be locked in her house. So, and I also I try to let parents base it on their kids' level of anxiety. So if they're not feeling anxious about it, we don't worry about it too much. But if it's hugely anxious, then we might do something like completely lock the fridge or move the fridge to the garage or something like that to just get it out of sight, out of mind. So that's usually how we prep. But I am really big on teaching kids what they can eat and not eat, because the world is unfortunately not a perfect place. So there's not going to be somebody standing over them 24/7 saying you can or cannot eat this. And we can get kids who really know what they are allowed to eat and school, which of course is a nightmare half the time because food security at school and getting schools to understand that is a whole other conversation. I had kids at school where a parent comes in to pass out cupcakes and they go, oh no, I can't eat that. That's not PWS safe. Or that's not safe for my stomach. So teaching those rules around food really early is really, really helpful.
Yeah, we won't talk about schools today, but you do have a whole paper for school psychologists that might be helpful for folks in that area. Is that right?
Yes, I do. I think it's called a primer for school psychologists. What do we call it? PWS, a primer for school psychologists. And if anyone wants it and they want to email me, I will send it to you. More than happy to. And that I think is a good primer for kind of anyone, because it goes over a lot of I didn't even go over all the behaviors that come with PWS, but we could be here for several days. So it goes over all the common behaviors. It goes over the brain differences and the physical features that impact these behaviors, as well as typical like food security measures, like IEP-related supports, everything you could possibly want in there.
Is there a plan as you go forward to sort of roll out some of these programs like the parent training program so other folks can kind of access it and use it?
So the parent training program, actually what we're doing with it right now is translating it into Spanish. We one of the huge barriers to getting people access to stuff that they need is language barriers. So we have completed I shouldn't say we, I have not. My Spanish I'm learning. My husband's Peruvian, so I'm learning Spanish, but it is nowhere near good enough to translate. So I hired a BCBA that practices both in Spanish and in English, and she's done the initial translation, and we're going to go look back and go about getting that validated and then run a pilot study on it. So that's kind of where we're at with that now. I am also I run the parent training program not on a one-on-one basis, which is how I would love to do it, is everyone gets the BCBA, but insurance doesn't fund ABA for PWS a lot of the times. So what I've done is I'm running it as a group. So I cap it at 15 parents participating. It's free for the parents to participate. And I do it on like a rolling basis. But the goal in the future is to get some training specific to BCBAs and to get the program out to BCBAs so that they can use it and implement it as well. So that's kind of on the radar. The BCBA trainings and stuff is on the radar for like 25, 26.
Oh, that's awesome. Right on. Cool. Wow. Learned so much today about Prader-Willi that I did not know, and I had a lot of misconceptions, I'll say, and a lot of sort of biased thinking around it, and it's really been enlightening, and it really suggests that there is a lot of hope for these folks.
I think there is, and I think that with the newer research, like the clinical research that we have going into these drugs on hyperphagia, there's one that's really, really promising that's in clinical trials right now. It's called DCCR, that is showing outcomes not just on hyperphagia, but also on some behavioral outcomes and anxiety, which is amazing and could be life-changing.
Game-changing.
For people with PWS. Yeah. So how my focus has shifted a lot is before we were really focused on how do we reduce these big behaviors of concern, of course, especially with the older generations of people with PWS who didn't have the benefit of everything we have now. But now I'm like, skills. We got to teach skills. We got to teach emotional regulation. We got to teach you how to cook. We got to teach you how to be independent. You have to know how to play. Like, all these skills are so important because if we can deal with the hyperphagia, we can open the world up for kids with PWS. So my focus has really shifted over to that because I'm like, just one day we could just get a medication, then we could really, really change people's lives. And that's, I think, another tricky thing of PWS is there has to be so much collaboration between all the medical providers and the therapists and ABA and everything. And if we could just all get together and get on the same page and get these kids prepared, like they could do anything.
Well, we're lucky to have you, and we're lucky to have you. And I really appreciate you coming on and tell me all about it.
Yeah, of course. There was only one thing that I meant to mention before that I wanted to mention when I was talking about the ARC program. I kind of alluded to this, but we don't typically recommend food reinforcers for people with PWS. So the ARC calorie system was kind of like a unique system within a environment that could host it. When I'm working with kids and parents, I usually do not. Like, it's kind of counterintuitive because you have this huge motivating reinforcer.
Sure.
But because it causes so much anxiety, we typically don't recommend food reinforcers. But I meant to emphasize that back there. But I
appreciate that. No, and I think the pieces that I kind of took from that study were the big thing that I really liked, and I said it already, is the idea that the restriction can actually be a real positive and be something that they actually want. And I think that's a really important thing for folks to think about. And then as well, I mean, I think, just token economies and reinforcement can really have an effect. It doesn't have to be food, and can really make a big difference. So yeah, really cool. Really cool work you're doing. Really appreciate it.
Thanks. I enjoy it. I love the PWS community. Is so, if you ever get the ability to work with them, they're so open and they're so kind and they're so supportive and excited about especially ABA research. So I really enjoy it. I'm so lucky to have fallen into ABA and also to have fallen into such a wonderful community to work with.
Love that. Well, thanks for coming on the podcast.
Of course, it's been my absolute pleasure. And if anyone wants information on PWS, you are welcome to share my email. I would love for you to email me. I do any kind of free training I can for any BCBA who wants it. So the more I can share information, the more I can help. I'm on board for it.
So cool. Thanks, Kasey.
If you enjoyed this episode, I encourage you to check out other episodes that highlight behavior interventions for those with genetic syndromes, like episode 6, Down Syndrome and Behavior Analysis with Dr. Nicole Neal, episode 27, where Dr. Val Saney shares some of his research on DiGeorge syndrome, episode 39 with Doug Woods talking about behavior therapy for Dickinson-Tourette syndrome, and episode 137, Behavior Analysis and Fragile X Syndrome with Katarina Monlux.
And please follow us on Instagram @BehaviorSpeak.